Hello, my name's Martin Porter. I'm a consultant orthopaedic surgeon with a special interest in hip and knee replacement surgery. I want to talk now about revision hip replacement. Well, the first thing to say is, what is revision hip replacement? What is this word revision? It's a medical term we use all the time as hip surgeons, but to lay people, what's a revision? A revision, quite simply, is a redo. Patients had a previous hip replacement. For whatever reason, it's gone wrong or it's not working, and there's a refashioning or revision of the operation. Now, the reasons for revision are really multifactorial. I'd just like to go through a set of moderately common scenario sets as to why someone may need a revision of their hip replacement. I think the most obvious one is that a patient's had a hip replacement, it's worked for many years, 15, 20 years, and quite simply the artificial hip is wearing out. So there may be loss of the polyethylene, wear of the polyethylene. The polyethylene is released into small particles, and these small particles can induce a biological reaction. And the biological reaction leads to bone resorption, so-called osteolysis, and the bone resorption then causes loosening of the components. So a not uncommon reason to revise a hip is because the socket's worn and the socket is loose. Sometimes the stem can be loose as well with the osteolysis, although with modern designs, femoral component loosening per se is less common now than the later effects of acetabular component loosening. Now, early on, the symptoms of loose components are pretty mild. You can certainly look at an X-ray and see evidence of loosening, and quite often the patient has very few symptoms. And the reason for this is because the loose hip, the joint doesn't have good nerve supply. So although the hip may be moving around with small deflections, the symptoms aren't normally that bad. But if the femoral component is loose, it's not uncommon to get some start-up pain when the hip is first loaded up, and then the pain slightly less as they walk further on it. With acetabular component loosening, there's sometimes a return of groin pain, mild groin ache that can occur with the component being loose. If it is loose, it's normally fairly obvious on the X-ray. The surgeon can see debonding of the component from the bone, and sometimes the effect of osteolysis, which can lead to areas of bone resorption. Another reason to revise a hip may be an early complication, and unfortunately we do see infection around the hip joint, and this can be a very difficult operation to carry out. A deep infection can be associated with quite significant soft tissue destruction caused by the bacteria. And with a infected case, appropriate investigations and workup is necessary, sometimes scans, aspirations, blood tests, and a careful evaluation. But the principles of the operation are to remove the implant. If the hip is deeply infected, it's not normally possible to salvage the joint because the joint surface is covered by a biofilm or a bacterial film, and unless the implant is removed, the likelihood of resistant or recurrent infection is very high. So the surgeon opens up the hip, has to take the implants out without damaging host bone, cleans up the bone thoroughly using water lavage, antiseptic solutions in high volume. And then there's a matter of debate as to whether the hip can be put back together at the same operation. And we sometimes do this with a cemented prosthesis where we use high doses of antibiotic in the cement to fix a cemented hip replacement in. But the other alternative is to a two-stage revision, where the first stage of the operation is to take everything out. We may put some antibiotics into the wound. It may be antibiotic beads. It may be a spacer shaped like a hip replacement, which contains high doses of antibiotics, such as 4 grams plus of vancomycin or tobramycin, other antibiotics, which allow elution of the antibiotics into the soft tissue. And then close the hip up and wait for clinical signs the infection is resolved. At a later date, 6 weeks, 3 months, whenever, according to blood tests, then go back in and put another hip replacement back in. So those are the differences between a single-stage revision or a two-stage revision for deep infection. Another cause why a surgeon may revise a hip is because there's been a fracture. Perhaps the hip's been slightly loose over a period of time, and the bone fractures because of the loose prosthesis. or else the implant's well fixed and the patient has a nasty fall and the bone, the thigh bone, breaks around the hip. And then it's a matter of treating that complication. There are two principles. Very simply, if the hip is well fixed, we normally try and fix the bone using special plates. If the hip is loose, we have to treat the loose hip and the fracture at the same time, in which case the hip comes out and we use a variety of different implants to try and treat the fracture of the hip at the same time. Another reason why a surgeon may revise a hip is because a patient has persistent or recurrent dislocation of the hip. The hip keeps coming out of joint. And if a hip comes out 3 times plus, it's a fairly normal, well, it's an indication normally to revise the hip. And there are a whole plethora of operations that can be done according to the findings. Sometimes we can just put a stabilisation ring around a cemented prosthesis, a so-called PLAD, a posterior lip augmentation device. In other scenarios, we have to take the whole hip out. The acetabular component may have to be repositioned, so that has to come out. Sometimes we contain the stem, sometimes we have to change that. So it really depends on an individual case assessment as to why we think the hip is dislocating. At the extremes, we can either put in a more constrained liner for the cup, and we can increase the head size. So there's a spectrum of operations. The PLAD or the PLAD is often can be done fairly quickly with minimal soft tissue dissection, and can be used if the orientation of the components is pretty good, and we can deal with it using a PLAD procedure. If the components are not well positioned, they have to be repositioned, and if they're loose, they need to be revised. So I always tell my patients with dislocation that we have to be prepared to do a number of things as we see fit during surgery, and we need a good supply of scenarios and preoperative planning, so we make sure that we can cover our bases. There are occasions where I sometimes get asked, you can only have 2 operations, you can only have 1 redo or revision or whatever, and that's not true. I mean, it might be true if it really depends on what's gone wrong with the hip, and unfortunately sometimes, particularly if it's a devastating infection, for example, you may find in rare circumstances that the damage is such that it's deemed best to remove the prosthesis. Often that's not the case, and it's very common we can do something, but this needs to be discussed with you as an individual as to what the problem is, what the expectations are, what's involved. But there's no set number of operations that can be carried out, but it's intuitive that the surgeon would like to actually get it right the next operation for it to last as long as possible. The types of problem we see are really very variable, from relatively straightforward operations such as revising a socket that's been in for say 20 years. We can go in and just revise the socket and perhaps do a cement-in-cement exchange of the stem. And at rare occasions, unfortunately becoming increasingly common, we see the late effects of multiple problems with the hip, in which case we may have to do major bone grafting, repair of the pelvis, and sometimes major resections, very similar to tumour surgery, where quite simply the hip replacement has caused extensive damage to the femoral bone, sometimes replacing major segments of the femur, and very rare occasions even the whole femoral segment, so revising the hip and the knee at the same time and having a major tumour reconstruction.